Allergy and Immunology 7. Anaphylaxis. Anaphylaxis is defined as the worst form of allergic condition or acute event. It is synonymous with the term immediate hypersensitivity. Anaphylaxis is defined by severity, not the cause of the reaction. Brain must already have been sensitized to the antigen. Ig binds to mast cell, main to the release of the granule, then histamine, prostaglandins, and nucleotides will result in the abnormalities that essentially define anaphylaxis. Anaphylactoid reactions are non-Ig related, occurring identical and treated the same way but do not need preceding sensitization to the antigen. Respiratory thermodynamics. The coil of anaphylaxis are the same as the coil of any allergic event such as insect bites and stings. Medications, penicillin, phenytoin, lamotrigine, quinidine, rifampin, sulfa, and foods. Latex is a very important cause of anaphylaxis in healthcare workers. Trigger anaphylaxis. Sensitization. Initial sensitization to antigen. Upon re-exposure, Ig binds to mast cells, leading to release of their granules, histamine, prostaglandins, and leukotrienes. Anaphylaxis, hives, itching, constriction of airways, swollen tongue, wheezing, dyspnea, tachycardia, nausea, vomiting, or diarrhea, dizziness or fainting, and hypertension, death. Symptoms include rash present with any allergic reaction, hypotension, tachycardia, respiratory distress, shortness of breath, wheezing, swelling of the lips, tongue, or face, stridor. There is no specific diagnosis just to define anaphylaxis. Treatment is as follows: epinephrine, antihistamines such as diphenhydramine, H1 blocker, and ranitidine, H2 blocker, glucocorticoids such as methylprednisolone or hydrocortisone, emergent airway protection if needed, inhibition of cricothyroidectomy. Urticaria is considered part of anaphylaxis, not just an allergy. Angioedema. Angioedema is sudden swelling of the face, tongue, eyes, and airway, commonly due to a deficiency of C1 esterase inhibitor. There is a characteristic association with the onset of minor physical trauma or the recent start of ICU inhibitors. Angioedema often has an idiopathic origin. Hereditary angioedema is characterized by sudden facial swelling and stridor with the absence of pruritus and urticaria. Hereditary angioedema does not respond to glucocorticoids or epinephrine. Angioedema can swell the eyes shut. The best initial tests are decreased C2 and C4 in the complement pathway and deficiency of C1 esterase inhibitor. Treatment is as follows: ensure the airway first, as the process can evolve rapidly. Acute attack, fresh foreign plasma, ecallantide or ecatibant, urticaria and early respiratory compromise, epinephrine, azithromycin, and steroids. Hereditary angioedema with severe laryngeal involvement, C1 esterase inhibitor concentrate or recombinant C1 inhibitor concentrate. Bradykinin B2 receptor antagonist, ecatibant, kallikrein inhibitor, ecallantide, Lanadelumab antibody against kallikrein. Prophylaxis for cervical and dental procedures which can precipitate angioedema. Antifibrinolytics, tranexamic acid, decrease C1 protein and therefore decrease the production of bradykinin. Androgen, stanozolol, infusion of C1 esterase inhibitor, recombinant or plasma derived. Antihistamines, glucocorticoids, and epinephrine are not effective for angioedema. They are helpful for anaphylaxis, not for C1 esterase inhibitor deficiency. Angioedema treatment. Ensure airway protection first, and epinephrine. Acute therapy, fresh foreign plasma, ecallantide, and ecatibant. Long-term therapy, androgen, stanozolol. Urticaria is an allergic reaction that causes sudden swelling of the superficial layers of the skin, causing include insects, medications, and physical agents such as pressure, dermatographism, cold, and vibration. Treatment is as follows: 1 antihistamine, hydroxyzine, diphenhydramine, phenidine, loratadine, or cetirizine plus ranitidine. 2 leukotriene receptor antagonists, montelukast or sulfated 4.7 urticaria localized anaphylaxis with a wheal and flare. Allergic rhinitis. Seasonal allergies such as hay fever are common. This is an IgE-dependent triggering of mast cells. Symptoms include recurrent episodes of watery eyes, sneezing, itchy nose and itchy eyes, inflamed boggy nasal mucosa, fever of violaceous turbinates, nasal polyp. Allergic rhinitis is most often a clinical diagnosis of the recurrent episode of hyperpigmentation previously described. Skin testing and blood testing for reactions to antigens may be useful to identify the specific etiology. Allergen-specific IgE levels may be elevated. Nasal smear may show a large number of eosinophils. Treatment prevention with avoidance of precipitating allergen, close windows and use air conditioning to avoid pollen. Get rid of animals to which the patient is allergic. cover mattresses and pillows, use air purifiers and dust filters, intranasal corticosteroid sprays, antihistamines, loratadine, nimacetine, fexofenadine, bromopeniramine, intranasal anticholinergic medication, ipratropium, desensitization to allergens that cannot be avoided. Primary immunodeficiency disorders, CVID, common variable immunodeficiency. In CVID, P cells are present in a normal number, but they do not make sufficient amount of immunoglobulins. There is a decrease in all the subtypes IgG, IgM, and IgA. There is also a decreased response to antigen stimulation of B cells. CVID presents as recurrent sign of pulmonary infections in adults. Rates of incidence are equal in men and women. Bronchitis, pneumonia, sinusitis, and otitis media are common as are giardiasis, foods like intestinal malabsorption, increase in autoimmune diseases such as pernicious anemia and seronegative rheumatic diseases. Tip: the clues to CVID are reduced output of P lymphocytes, a normal number of B cells, and a normal amount of lymphoid tissue, example nodes, adenoid, and tonsil. Treat each infection as it arises with antibiotics. Chronic maintenance for CVID is with regular infusion of intravenous immunoglobulins. X-linked Bruton agammaglobulinemia. X-linked agammaglobulinemia presents in male children with increased sign of pulmonary infection. P cells and lymphoid tissues are diminished. There is a decrease or absence of the tonsils, adenoid lymph nodes, and spleen. T cells are normal. Treatment and management of the infections as they arise. Long-term regular administration of intravenous immunoglobulin keeps these children healthier. Severe combined immunodeficiency. The word severe combined immunodeficiency (SCID) means that there is a deficiency in both B and T cells. This results in infections related to both deficiencies. B cells decrease immunoglobulin production leads to recurrent sign of pulmonary infection beginning as early as age 6 months. T cells markedly decreased number of T cells give many of the infections that you would see with AIDS patient, example PCP, varicella, and candida. Treat the infections as they arise. In addition, these patients should undergo a bone marrow transplant which can be curative. IgA deficiency. These patients are also present with recurrent sign of pulmonary infections. The difference between this syndrome and the others is atopic disease, anaphylaxis to blood transfusion when blood is given for a patient who has normal levels of IgA, flu-like condition with fat malabsorption, increase in the risk of vitiligo, thyroiditis, and rheumatoid arthritis. Treatment is management of the infections as they arise, with only blood that is from IgA deficient donors or has been washed. Intravenous immunoglobulin injection will not work because the amount of IgA is too low to be therapeutic. Great amount of IgA and intravenous immunoglobulin may provoke anaphylaxis in the same way that a blood transfusion does. Hyper-IgE syndrome. This presents with recurrent skin infection with staphylococcus. Treat these infections as they arise and consider prophylactic antibiotics such as cycloxacillin or cephalexin. Scott-Ulrich syndrome. This is an immunodeficiency combined with thrombocytopenia and eczema. T lymphocytes are markedly deficient in the blood and the lymph nodes. Bone marrow transplantation is the only definitive treatment. Chronic granulomatous disease. Chronic granulomatous disease is a genetic disease resulting in extensive inflammatory reactions. The result is lymph nodes with purulent material leaking out. Heptus ulcers and inflammation of the nares are common. Granulomas may become obstructive in the GI or urinary tract. Where is the most likely diagnosis? Look for infections with the odd combination of staphylococcus, Burkholderia, nocardia, and aspergillus. Test for hydrohydrohodamine and chronic granulomatous disease. Diagnostic testing. Abnormal results of nitroblue tetrazolium testing or dihydrohodamine testing detect the decrease in the respiratory burst that produces hydrogen peroxide. This is a decrease in NADPH oxidase which generates superoxide. Primary immunodeficiency disorder. Common variable immunodeficiency CVID. Low B cell output, normal T cell. X-linked Bruton agammaglobulinemia, low B cell, normal T cell in young male children. Severe combined immunodeficiencies, SCID, low B cell and T cell, analogs to HIV. IgA deficiency, atopic disorders, anaphylaxis. IgE syndrome, skin infections, example staphylococcus. Scott-Ulrich syndrome, low T cells, normal B cells, low platelets, eczema. Chronic granulomatous disease, lymph nodes with purulent material, infections combined with staphylococcus, Burkholderia, nocardia, and aspergillus.